Hello, today I am going to talk on refractive errors. And before starting the lecture, I am going to explain a little bit of confusion that at undergraduate level, you are supposed to know what are the basic things and you are not supposed to know the very advanced things. I have seen in my experience that students usually have a pretty good knowledge about their subject, but when the exam comes, they are so confused that the examiner is expecting the very simple and basic things, and they are jumping just on the advanced things. Keeping this thing in mind, I have started this series of lectures. So in my first lecture, I am trying to talk on refractive errors from the point of view of your exam and from the point of view if you become a general practitioner in the future. So when we talk about refractive error, first of all, we need to know what is the normal thing. Normal state of refraction is called emetropia. Emetropia means when the rays of light which are coming from infinity, they form a sharp and well-defined image on the retina. Parallel rays of light which are coming from infinity, they are forming a sharp image on the retina. This is called emetropia, and the person does not have any type of refractive error. The problem is ametropia. Ametropia means the parallel rays of light coming from infinity does not form a sharp image on the retina. Now, ametropia is further subdivided into myopia, which is also called as nearsightedness, hypermetropia, which is also named as long-sightedness, and astigmatism. Some people also include the aphakia, that is the absence of the lens, and presbyopia, that is the decrease in the near vision with the increasing age. These two things also in the refractive errors, but in my opinion, these should be kept separate and should not be included in the refractive errors. Today, in this small talk, I will just talk on myopia. So, myopia means nearsightedness. First, we come to the signs and symptoms of the patient. The I will, as I told you earlier, I will talk very basic things, and if you remember these basic things, I don't think that you will feel any sort of difficulty in any conversation or in any viva or in any examination. The first thing is that in myopia, what happens? The rays of light, they do not form the image on the retina. The rays of light form an image in front of the retina. For example, this is the retina. This is the retina. The rays of light should form the image here right on the retina. But they are forming the image here in front of the retina. This is called myopia. Simply, this is called myopia. The rays of light are forming the image in front of the retina. Now, what will be the patient's complaint? Patient will say, as the image is in front of the retina, the patient will have to move towards the image like this to sharply visualize the object. That's why the patients who have myopia or minus number, they used to see the television, and we say that usually if the patient is a child, we forcefully uh, ask them to get back and see from the right distance, but they cannot see from the right distance because the image is forming in front of the retina, so they have to move unconsciously in front to see the normal. And that's why the myopic patients also see cannot see the normal thing written from the normal distance, they will see like this because of the same reason. So the myopia is then their complaint will be that they cannot see comfortably from far and they are comfortable with the near view. Now, this is the basic symptom and or sign, whatever you call it, which a patient will come to you with. Now, I will come to the types of myopia. There are three types of myopia. In short, number one, axial myopia, in which the axial length of the eyeball is a little bit large. The second one is curvature myopia, in which the curvature of the cornea is more steep. For example, it is normally, if it is like this, it is more steep like this. So it will convey the light of rays more. So it is not like normal. It is curvature myopia. The third one is index myopia, in which there will be changes in the refractive index of the crystalline lens of the eye. That will again cause increased refraction and will cause the formation of image in front of the retina. The most common of these is the axial myopia. The most of the people we see around, they have axial myopia, and some may have curvature myopia, and index myopia is um, mostly seen in the old patients who are developing cataract. So today our concern is physiological myopia, which will include axial myopia and curvature myopia up to 6 diopters of power, 6 diopters spherical. If the myopia is more than 6 diopters, it is labeled as pathological myopia, in which there could be changes on the retina and some other things. But now we will stick to our topic, that physiological myopia, because of increased axial length or increased curvature. Uh, Up till now, we have discussed the definition of myopia, the causes of myopia, symptoms of myopia, and now we will discuss the treatment options of myopia. There are again three treatment options of myopia. Number one, and the best one, is the use of glasses, and we use concave lenses. Concave lens, what does concave lens do? Concave lens diverges the light, and the light in myopia which is forming in front of the retina, when we prescribe him with a concave lens like -1 or -2, it will diverge the light and will form the sharp image on the retina. So keep it in mind that the key point or the principle is that to move the image which is formed in front of the retina is to move it back on the retina. There could be many methods. One of the methods I just described is the use of concave lenses, which we calculate by the process called diffraction, in which we use retinoscopy, which is the conventional method and the most reliable method. And now the recent instruments like autorefractometers are being used, where they give the precisely the number of the refraction. For example, the number of the patient becomes -2 diopter spherical and -0.75 diopter cylindrical at 180 degree. So this is the number of the patient. This is the objective number. We will not give it as such. We will do the subjective refraction. If maybe we give the patient plus 1 point, sorry, -1.5, and he may become 6/6. We will do certain other tests to make sure that he's not using his accommodation and is comfortable, and subjective verification is very important. So after glasses, the option number two is the contact lenses. If the patient is annoyed of glasses, or if the glasses are cosmetically unacceptable to him, then you can advise him the contact lenses. This is the option number two. I'm talking about keeping in mind that I'm addressing the audience of the fourth year. The option number three is the refractive surgery. In refractive surgery, the most latest one is the femtolasic, and the second one, which is very much in use and has been a little more time tested, is excimer laser refractive surgery, uh, or photorefractive surgery. Both with contact lens and photorefractive surgery, the main problem which can happen is that uh, you can have in contact lenses you can have recurrent infections, you can have allergic reactions, and you can have so much severe infection that you may lose the eye. Similarly, in refractive surgery, you can uh, overcorrect the patient, undercorrect the patient, or you may even cause a infection which is very rare, and you may also lose the eye. But these two modalities are very well in, especially the refractive surgery, but keeping in mind that it is irreversible, so you have to be very careful. Uh, at the level of fourth year, you just need to remember these three treatment options. Number one, glasses, the best one. Number two, contact lenses. Contact lenses also work on the same principle like glasses. Only there is a formula in which they just change a little bit of the number, because the glasses are worn 15 millimeter um, in front of the cornea, and the contact lenses are in direct contact with the cornea. That working distance is to be taken out. That is not your concern. That is the concern of the optician who will dispense the glasses. Similarly, in refractive surgery, your main concern is that you have to reshape the cornea. The cornea is more conical. Whatever the cause is, whether it is axial or whether it is curvature, you cannot shorten the length, axial length of the cornea. Only the thing you can control is that you can change the shape or contour of the cornea, which is more steep. You will make the cornea less steep, or we can say you will make the cornea a little more flat. Like if in myopia, cornea is like this one steep, you will do excimer surgery, and or if any other refractive surgery, and the curvature of the cornea will become less steep and more flat like this. This will cause less refraction, less convergence, and it will cause the formation of image right on the retina, on the macula. So this was a brief discussion on myopia according to my point of view, which you should know. Uh, Anything beyond this, if you know at the level of fourth year, is not bad, but if you know at least these facts, uh, I feel these are enough. Thank you very much for now, and see you in my next series of lecture on some other topic. Thank you very much.